Now, the next item in the agenda is a discussion of the systemic therapy options for patients with more advanced cases, more advanced stages of renal cell carcinoma. I think many of you, or most of you, know me, but for those who don't know me yet or don't know me well, my name is Jaime Merchan. I'm an associate professor of medicine at the University of Miami and Sylvester Cancer Center. I'm in the division of medical oncology. In terms of my background, after I finished my medical school in my home country in Ecuador, I did my residency in internal medicine here at UM. I also was chief resident, did an extra year, and after that I pursued my oncology fellowship at Harvard Medical School and the Beth Israel Deaconess Medical Center for about 3 years. Also, after those 3 years, I pursued extra training in research, in drug development and translational research. And so I spent 2 extra years at MIT and Harvard to further specialize and pursue my interest in research. After that, I went to Mayo Clinic, not in Jacksonville, but in Rochester, and I started developing a kidney cancer program there because my interests at Harvard, where there were a lot of my mentors did kidney cancer, was to bring trials in kidney cancer, and we did that. And then in 2006, wow, it's almost 13 years already here. I was a junior faculty still. The chief of Hemong at that time, where there was a combined division, Dr. Joe Rosenblatt, convinced me about the beauties of Miami and the weather and everything compared to the cold in Rochester, and I decided to come here. And my efforts, both research and clinical, have been in the treatment of genitourinary cancers, and my heart is in kidney cancer, where I have a laboratory and I do research in kidney cancer in the laboratory, and also in the clinic I see patients with kidney cancer and other urological malignancies and do clinical trials to try to bring the newest and latest treatments for our patients here in South Florida. So let's talk a little bit about the epidemiology. What is kidney cancer? Where does it stand compared to other cancers in the US? These are statistics and predictions for 2019. And it is expected that in the US only, there will be about 73,000, so almost 74,000 new cases of kidney cancer in the US, patients with newly diagnosed kidney cancer. And of those, unfortunately, about almost 15,000 patients may die of the disease. It is about 4 to 5% of all the cancers in the US, kidney cancer, and about 3 to 4% of cancer-related deaths. It is usually a disease more common in males than females. It occurs at any age, as Dr. Gonzalez said, but in general, this occurs at the median age of 60 years. However, we see a significant number of patients with kidney cancer. We have seen patients as young as 30 years old, and then from then on, any age. And there are several risk factors that are important, and I always tell my patients that are risk factors for kidney cancer and that we have to try to avoid, including smoking, hypertension, overweight, and more than overweight, obesity is a significant and well-recognized risk factor for kidney cancer. There are some hereditary conditions like acquired polycystic kidney disease, patients who develop multiple bilateral cysts in the kidney that with time may develop into kidney cancer. Patients with who are on hemodialysis and chronic renal failure and stage renal disease can also are at risk to develop kidney cancer. And finally, occupational exposure. This is becoming less and less because of the regulations, environmental regulations, etc. But in the past, this was a somewhat important risk factor like exposure to cadmium, asbestos, or petroleum byproducts. In this pie chart that you see on the right of the screen, this is the distribution of kidney cancer stages at presentation. So when we see patients with kidney cancer, the great majority actually are seen on what is found at surgery, whether there are lymph nodes, whether there is residual disease, or whether there are some metastases that showed up after surgery. About 10 to 15% of cases, patients present with what we call regional or locoregional disease, which is that the cancer is not only the kidney, but is around the kidney, like the lymph nodes, or passes through several layers of the around the kidney. And about a quarter of the cases with kidney cancer, patients present with advanced disease, with disease that has metastasized to different organs. Okay, now the tricky part about kidney cancer, even if it's localized, is that there is still a chance, okay? And the numbers are very variable depending on the studies that we read, but up to 30% of patients with localized disease, which is the 60 to 70% of the cases, may be at risk and could eventually develop relapse or metastasis. Kidney cancer comes in different flavors. There are different subtypes of kidney cancer. There's not just one kidney cancer. And the most common type, which occurs in about 3/4 of the cases, is called clear cell or conventional type renal cell carcinoma. The second most common type is the papillary type renal cell carcinoma, which there are type 1 and type 2, which are different in terms of biology, in terms of clinical behavior and aggressiveness. Less common types of kidney cancer, like 5% of the total, is the chromophobe, which usually is a less aggressive type of tumor and mostly treated by surgery if that is feasible. Other uncommon type is called oncocytoma or oncocytic renal cell carcinoma, which also occurs in about 5% of the cases. However, in the last couple of years, there have been many other subtypes, histological or pathological subtypes of kidney cancer that would make an innumerable, too numerous to count, list of subtypes. But these are the 5 more common subtypes. Each of the subtypes, thanks to research that has been done, genetic research and research into the molecular alterations that lead to kidney cancer, have associated the different subtypes of kidney cancer, not all of them, but some of these subtypes, with mutations or alterations in genes that are believed to induce or to increase the risk of the development of the kidney cancer. Okay, one of the most common ones, especially in the clear cell kidney cancer, which occurs in the great majority of kidney cancer patients, is a gene called VHL or von Hippel-Lindau. And I'm not going to go into details, but this is an important gene that actually is a suppressor. It suppresses cancer. And in patients who have clear cell kidney cancer, the great majority, this gene is non-functioning. So the suppressor, the brake against cancer, is gone in these tumors, in clear cell renal cell carcinoma. So this is a little busy slide, and I think we cannot, I'm not sure if we can see the mouse, but so this slide has 3 big components. In the upper part, you can see, like, I think it's beige, which is a tumor, okay, in the upper part. Below, there are these layers of like a small tube in red, which are the blood vessels. On the left part, these cells that look like stars and these ovals on the left side, those are the immune cells. And also below, in the lower part, are the immune cells. So the objective of this slide is to summarize years and years, decades of research that have led to the development of what we use now to treat advanced kidney cancer. So the first part of the 1990s and in the early 2000s, actually when I was in Boston, when I was doing my fellowship training, there was a big hype about a discovery that the scientist who I had the honor to know and meet and talk a lot, his name is Judah Folkman. I don't know if anyone knows about the name Judah Folkman. He discovered that not only kidney cancer, but many cancers, it depended on the tumor blood vessels. They needed the circulation or blood vessels, new blood vessels to form in order to feed the cancer. This process is called angiogenesis, okay, or development of new blood vessels. So you can see here in red the blood vessel, that this says endothelium, that is the blood vessel. It sends like prolongations, which are capillaries, to feed the kidney cancer. There's blood coming into the tumor, oxygen, nutrients, and that's what the tumor uses to keep growing, right? So in the early 2000s, there was a lot of research about tumor angiogenesis. And that's what I did my research on when I was in fellowship with a scientist doing angiogenesis and kidney cancer. And because of this important discovery that tumors need blood supply in order to survive and to keep growing, Judah Folkman discovered several molecules, several proteins that were endogenous that we, our own bodies, can produce that actually could block this process of blood vessel formation. So, and that is what started this big field of tumor angiogenesis. And after that, there was an explosion of new discoveries and development of new drugs that were aimed at blocking this process of blood vessel formation, of tumor angiogenesis. And in kidney cancer, angiogenesis, the need for blood vessels, is so important that just blocking blood vessel formation is enough to halt the cancer and to stop the cancer growth. On the right side of your slide, you will see this box that says VEGF inhibition and a number very different drugs that are difficult to read or to pronounce, okay? But all of these agents, like some of them you may know, pazopanib, for example, sunitinib, axitinib, lenvatinib, right? Cabozantinib, are aimed at blocking this process of blood vessel formation. I said that this slide, this right part of the slide, took about 20 years in the making. Many scientists, many clinicians, universities, drug companies that developed and worked together to try to bring this, through research, to bring this to patients. So the first part of the 2000s, the mainstay of treatment for kidney cancer were the use of drugs that block angiogenesis, and still is, because of the process, the biology of kidney cancer. It needs blood vessels, okay? Even though what I will talk later about immunotherapy, kidney cancer is still a tumor that depends on blood vessels, and it is important to target or to consider targeting that at some point during the treatment. Then 2010 passed, and in the second decade of the 2000s, and much before that, there were new discoveries about how the tumors react or how the tumors interact with the body and with the immune system. Initially, like when the pathologists see the tumors, the kidney tumors, they see a lot of cells that are not cancer cells, but are inflammatory cells, right? That surround the tumor. And again, decades of research showed that the interaction between the tumors and the tumor cells and the cells of the immune system, which all of us have, or cells of the immune system, are all the time like the police monitoring, doing surveillance. Is there anything that doesn't belong to us? They go and destroy. And many times, like there are several theories that people say many people who don't have cancer is because the immune system is killing the microscopic cells. But what happens with some cancers? In some tumors, the cancer cells actually are smart enough to hide or to cloak themselves from the immune system. The immune system cells cannot see them. Or the immune cells can actually put a brake on or the tumor cells can put a brake on the immune cells. Even though the cells are there and ready to attack, the cancer cell produces substances that put a brake, and therefore the tumors progress. So from 2010 and until more recently, there has been an explosion of research, discoveries, and development of drugs that target the immune system to treat cancer. You may know the name of some agents, some drugs, for example, nivolumab, pembrolizumab, atezolizumab, and also here in the lower box on the left lower side, it says here CTLA4, that is ipilimumab, and the newly approved medications for advanced kidney cancer include all of them. Like some of them are investigational, like pembrolizumab, and we have several of our patients who are on clinical trials with this drug. Okay, but all of these drugs are being developed and are being studied in research to basically to hope to treat kidney cancer. So the take-home message of this slide is this three-part. Okay, the tumor, the fact that kidney cancers need blood vessels, and also that kidney cancers interact with the immune system in a way that the immune system puts a brake to the immune system, so they don't let the immune system kill the tumors. And the drugs that we are using now that have been approved are targeting one way or the other this triangle, I would say. All right, and please feel free to raise your hand and ask questions if you think that you would like to have some questions. All right, so this is a historical tour, again, that took probably more than 20 years in the making. And if we go back to 2005, when I was a very, very early junior faculty going to Mayo Clinic, I actually, we did some of the initial studies of sunitinib that brought it to the market, to the approval. Before 2005, there were very, very few options, and there was a big gap. And my nurse practitioner, Dalisa Tejera, will talk a little bit about that, expand a little bit on what was before this and then after that. But the upper part of the slide, you will see the names of the drugs that are approved for renal cell carcinoma currently. Okay? Starting in 2005, 2006 with sunitinib or sorafenib, and then there were like bursts of new approvals, like between 2010 and 2012, and more recently from 2016 on, a lot of new drugs. This is great, this is incredible, because from a disease that we had almost no treatment and there was no hope before 2005, now we have a large number of options. And that is great because that provides hope for the patients, right? The doctors can sit down and talk about the different options. So this is great, but there's also a challenge with that. There's different treatments, right? Which one is the best? How do we know which treatment to choose for each patient? The lower part of the slide, this is just a corollary of the upper part, is the percentage that you see is the percent of patients who have had survival more than 2 years or more with some of these treatments, right? Now, how does the doctor, how does the medical oncologist who specializes in kidney cancer decide or provide recommendations? It is a multi-step approach. First, we see the patient, we evaluate the patient, examine, do blood tests, etc. Okay, and depending on the type of kidney cancer, remember that there are different histological subtypes, clear cell, papillary, etc. Depending on the type and depending on how the patient is doing and the blood test, there is some set of criteria that have been developed called IMC Criteria, okay, that count like the time from diagnosis to need of treatment, how good the patient is doing. Many of my patients, they know that we ask, how are you doing? Are you able to do your things? Are you able to do your activities of daily living? That is called functional status or performance status. And what we basically do is that we use that information to guide us a little bit as to where the patients are and what treatments could we potentially offer. If the patients have anemia or not, calcium, platelet count, some subset of white blood cells called neutrophils, etc., right? And then what we do is part of these studies that led to these criteria set several guidelines that we can categorize each patient into different categories. Okay, and the importance of trying to stratify each case is because the research that has been done has basically shown that some treatments may be better for patients who are in one category. We call favorable risk or intermediate or poor risk, depending on how many alterations they have in these 5 or 6 factors that we did. All right? And this slide summarizes more or less the current landscape or the current landscape of treatment that we use. This is not written in stone, and this is not the Bible or something that all the doctors have to abide to, but this is just a guideline. And as Mark said, each patient is different, and each doctor is different. Okay? So we saw that sunitinib was one of the earliest drugs. It's an oldie but goodie. It is still a great option for some patients in first line. Okay? While for patients who meet the criteria to be like intermediate or poor risk, okay, they may be a better candidate for immunotherapies or for other drug combinations. An important question, so we talked about how do we treat patients, what helps us to choose or to recommend treatments. Another very, very important part of the recommendation for treatment is discussions with the patient. Okay, we sit down with the patient, we explain the status of the disease, we explain the options, the pros and cons, the side effects, and we make a decision together, right? So you see here that there are several options. You see one or the other, depending on the patient's, for example, history of other medical conditions, for example, or depending on the patient's preferences in terms of side effects or concerns about some side effects. We may recommend one treatment or the other, okay? So, Mark was saying that when he operates patients, okay, when he removes localized kidney tumors, we always talk and discuss about, like, can we do something to decrease the risk of recurrence, okay? There has been a lot of research in this, okay? This is a summary of results of several trials from 10 years ago, okay? This is history already, okay? Where sunitinib or sorafenib or pazopanib have been tried to give to patients with no cancer but had their tumors removed to see if it prevents cancer recurrence. Unfortunately, benefit you see here, there was no benefit compared to controls, to just standard of care, which is evaluation follow-up. Okay, and that's why it is so important, okay, to see what else can we do. And what else can we do? Because immunotherapy and the interaction from the body, the cancer and the immune system are so important in kidney cancer. Okay. The modern studies, the current studies, are basically assessing, investigating whether immunotherapy can prevent recurrence of the cancer. Okay, and we participate in this study in the center. Okay, and we are trying to answer that question. All right, we are very, very hopeful that immunotherapy, which seems to be working for some patients, may help try to decrease the risk. The only way of knowing is by completing the study, finishing the study, and doing analysis. But we always encourage our patients to participate in this and many of the other studies that we have. Okay. What is the future in terms of the treatment? We talked about that triangle, remember? The tumor, the blood vessels, and the immune system. And there have been treatments approved that target the tumor blood vessels alone and the immune system alone. The more modern trials right now, what they are trying to investigate is to determine whether a double approach, attacking the immune system and attacking the blood vessels, may work better than each system alone. All right? And there are several trials that have been done. Okay? The ones in stars completed accrual. Okay? We have one trial, the one that is in the center, and we have set some patients in it, and we believe it's very, very important because this may represent the future of how we treat kidney cancer. And many of us who follow the literature, we know that this probably will change how we treat cancer in the next couple of years. There are a lot of new agents and strategies that are under development for kidney cancer, from new generation immunotherapy agents on the left, to vaccines, to a new form of immunotherapy, which is called a Tcell therapy. And what they do is patients have their blood drawn, the lymphocytes are removed, the lymphocytes are redesigned to attack the cancer, and then the patient's lymphocytes are put back into the patient. This is mostly, right now, investigational. This is only investigational. And there has been interesting results, good results in other cancers, like in lymphomas or leukemias, to the point that this, what we call CAR T-cell therapy, the lymphocyte therapy, is approved for some lymphomas. For solid tumors and for kidney cancer, it's in the very, very early stages. There are a lot of challenges, a lot of side effects that have been found. So this is something that is a potential option, promising option, but it is still very, very early. And also, agents or drugs on the right side, T-cell agonists, that help the immune system get stronger to attack the cancer. And this is another very, very busy slide that you can see. Each of these small names and numbers is a potential strategy or a potential target for drug development. So you can imagine how much is being done right now in research, not only to treat kidney cancer, but many other cancers, and especially in the last 10 years, how much advances have been made for the benefit of the patients. Now, let's talk about some specific novel targets, and I think those are the last slides, which we have clinical trials for. On the left side of the slide, one target that has been untargetable as of yet, okay? But right now, there is a drug for it that is in investigation, okay? Is an internal circuit in the cancer cell called hypoxia-inducible factor, or HIF. We call it HIF, okay? And it has been very difficult to target because this protein is inside the cell, it's not on the surface, so we cannot create an antibody to go and block. But academicians partnering with some drug companies have developed a drug, okay, called PT2977 that is able to block this very, very critical protein for kidney cancer called HIV or HIV2. And this pathway, the HIV pathway, is so important because this HIV pathway is kind of like it starts a cascade of different other circuits that will lead for cancer progression. For example, HIV pathway enables the tumors to stimulate the blood vessels. It makes the tumors more invasive. It makes the tumors more aggressive. It makes the tumors take up more glucose. Okay, so blocking this central pathway, this HIV2 pathway, may be very, very important. We have clinical trials for that here at UM. Not all the patients can participate or meet criteria to participate in trials. There are specific strict criteria, okay? But what we do is we always look at our trials, match with the patients, and if we think that the trial is available and makes sense for a patient, we recommend that because we believe, compared to standard of care, that is the best option. Other target is the metabolism. We're targeting tumor metabolism with several drugs, and also one pathway is called the glutamine pathway, because tumors are addicted to this amino acid glutamine to make energy, because they don't make energy efficient enough. Another one that is in my heart is oncolytic viruses. Okay, this is a completely new area of research. Okay, and what are oncolytic viruses? Oncolytic viruses are these viral agents, pieces of DNA or RNA with an envelope that normally cause disease, cause the cold, the flu, chickenpox, measles, variola, etc. Okay, but it has been found that several viruses, okay, have the ability to target mostly or predominantly the cancer cells. On the left figure below, like the cancer cell here, the viruses are able to infect the cancer cells, multiply and destroy. While the normal cells who are on top, the virus enters and goes away. Nature and the nature of the cancer made it so that some viruses are specific and predominantly selective to tumors. Now, what happens, now let's go to the right figure. What happens when the virus is given to a patient, okay, or to a tumor? It infects the tumor, propagates, kills the cells. Again, this is in theory, okay? We are testing, we're investigating a good number of viruses here, right? But once the tumors get infected and killed, it causes inflammation, all right? And that induces several responses, like it releases new antigens that the immune system will now see, and now say, hey, there's something, somebody shouldn't be here, let's go and attack. And also stimulates the immune system, all right? And not only stimulates the immune system to attack one cancer, but other tumors as well, okay? And the hope is that with a virus, and for example with immunotherapy, this would be a good and a promising approach for patients with kidney cancer. Okay, we'll pass here. So in conclusion, we can say that in the last 10 years, there has been a significant progress in the therapies for renal cell carcinoma. We know now that immunotherapy and targeted agents are valid and beneficial options for patients with advanced kidney cancer. The novel immunotherapy strategies, like combining immunotherapies with agents that block blood vessels, for example, may change the standard of care in kidney cancer, okay, very, very soon. Like combinations, new generation immunotherapy agents, tumor metabolism, oncolytic viruses. But there are several challenges as well. There are several needs that we are actively working on. Individualized kidney cancer treatments, okay? Patients are different, tumors are different, the non-cancer tissue around the tumor is different. So this is a big challenge that we are right now trying to investigate and work on to try to more precisely determine which treatment would be the best for the patients. We need better treatments to prevent kidney cancer recurrence after surgery. We're doing trials to prevent that. okay? Better therapies for patients who have non-clear kidney cancer, which is the other 15 or 20% of cancers that are not clear cell. We use treatments for clear cell and they work in a good number of cases, but there's not much research being done, not because the investigators don't want to do research, but because to try to do research in those type of cancers, which are very rare, is difficult. There are no good laboratory models for these cancers to test new drugs. So we need more research and more funding for that. And novel targets, we still need to find new targets to develop new drugs to hopefully at some point cure kidney cancer. And the take-home message here is that while we have done a lot of progress in kidney cancer through bringing new treatments, there is still a good way to go in order to meet our ultimate goal, which is to get rid of kidney cancer, to get rid of the disease. I think the state of kidney cancer research is very, very good right now, okay, and is very promising. So there's a lot of hope for all of us, for the doctors and for the patients, okay? Working together, right, trying to get funds, trying to raise awareness about the necessity to fund kidney cancer research and to raise awareness about kidney cancer to be an important disease is critical. And that's why in part we're here. Thank you very much.